All right, so I want to bring us, we had, I think, a very helpful and thorough tour of where we do not want to go and why moving towards a US-style healthcare system where you have multiple payers, which is very distinct from what we have in Canada, which is predominantly a publicly financed single-payer system for essential or medically necessary healthcare. So I want to just return us very quickly and provide a short recap. So in this case, the plaintiffs are challenging the ban on extra billing, which means charging patients beyond the fees that doctors are paid by the public plan. They're also challenging the ban on dual practice, which prevents doctors from being paid by both the public plan and private payers. And then they're also challenging the ban on private duplicative insurance to cover medically necessary care already covered by the public plan. And so put simply, the Cambie case is about creating markets for basic medical healthcare. In this case, hospital and physician services, those that we go to and we don't walk away with a bill in our hands or are denied access because we don't have the private insurance to pay for that healthcare. So this litigation is about creating markets for basic medical healthcare in this country, and it's about maximizing profit-making opportunities by removing restrictions placed on doctors, for-profit facilities, whether that's surgical clinics or private for-profit hospitals and their investors, and also private insurance companies. So that the goal here is to have multiple payers and to allow private payers to be billed and also to at the same time be billing the public purse. Make no mistake, this also means that we would most certainly see US-style healthcare. So if the plaintiffs are successful, our publicly financed single-payer system could be easily lost. And I should note that the BC Medicare Protection Act is similar to legislative regimes used in other provinces to maintain publicly financed healthcare. And what this legislation does here in BC, like it does in other provinces, is it's used to contain costs contain public costs as a publicly financed single payer system. And it also, the intent behind the legislation is to prevent Health Human Resources from shifting out of the publicly financed system to the privately financed system where physicians may be compensated more, and there are a number of ways that profit making can be achieved in a way that it is currently prohibited as we have with our current legislation. So I want to make two important distinctions. What is at stake with Cambie is private financing, often called two-tier or parallel private healthcare. And this refers to private non-government payment of hospital and physician services, either out of pocket or by private insurance. And it's important to note that there's no outright ban on privately financed healthcare in Canada. There's no legislation that prevents doctors from working entirely in private facilities or for patients paying out of pocket. What is at issue here is doctors must choose whether they're in the public system or not, but they can't be in both and be billing both separately. If the plaintiffs are successful in this challenge, we would see much more for-profit delivery, likely from US and UK investor-owned hospital chains. And I think from Dr. Himmelstein, we should be very concerned about what that would mean in terms of having those companies and their business models entrenched within our system. Separately, we need to keep in mind that private for-profit delivery is a form of privatization, often in the case that we're familiar with in Canada, contracting out or outsourcing publicly funded services. And so this is distinct, although I think there's a blurring, and there's, with a successful challenge, if the plaintiffs are successful, we would certainly see much greater private for-profit delivery in our provinces and across the country. So one of the questions that I was asked to provide a bit more detail on is one of the key issues with private financing and what's at stake with Cambie is the fact that the movement towards private financing drains public resources out of our system, and in fact increases public wait times. And so much of this evidence has been brought forward in the Cambie case itself by expert witnesses who have themselves written widely and researched these topics quite widely, as well as some of the evidence that's been brought to bear from the BC case and what we've seen emerge in our health system over the last 20 years. From a seminal review of the experiences of OECD countries with private financing, the authors of this prominent study, when looking at all of these experiences, concluded that public sector waiting lists and times are longer in nations with parallel private sectors. A parallel private sector may in fact draw resources out of the public sector and/or put in place incentives that have the effect of increasing waits in the public sector. Waiting lists for publicly financed services are likely to respond to infusions of public, not private finance. And these findings are consistent with many other studies, including from looking at the case of Australia, as well as the case of the UK, particularly the experiment with private insurance in England. It also confirms what we know from a study done looking at cataract surgeries among other elective procedures in Manitoba. There was a brief time in the late 1990s where facilities in the private sector could charge fees to patients on a private pay basis to access those cataract surgeries more quickly. And that study, in fact, found that wait times were longer for surgery patients in the public system whose surgeon worked in both publicly financed and privately financed facilities. More recently, we don't have published literature on this yet, but what we do know from media reports and from the experience to date in Saskatchewan, in 2016, the province began a one-for-one MRI experiment. So individuals were encouraged by government to pay privately for an MRI scan, and the private clinic would provide a scan to a patient on the public list. What we saw over 2015 to 2019 was that the public MRI waiting list actually doubled. So that would again suggest that we're pulling resources out of the public sector into the private sector, and it's in fact creating longer waits as people are not able to access the care in the public system because many of those health professionals are spending more time in the private sector. So this is the basic point, that many physicians will maximize time where they can earn most. Other professionals may be drawn into the private system for pay, predictable hours, reduced workload, as both Drs. Himmelstein and Dr. Woolhandler noted. One of the issues that we see predominantly in a for-profit sector is cream skimming, or the drive to focus on those procedures that are most profitable, and they tend to be elective procedures. Diagnostic imaging is also another one, and so in a lot of cases, these elective procedures may be healthier, wealthier, and it may be more predictable work. It may have lower workload for those professionals who are choosing to work in the private sector. As health human resources shift out of the public system, patients wait longer on public wait lists. And I think the basic fact here is that healthcare providers can't be in two places at once. And the argument that simply, well, just increasing the number of physicians that we graduate, or the number of imaging technologists or nurses, the reality is that those resources will continue to shift into the private sector if the incentives are there to encourage that. So that doesn't actually address the issue. The bottom line is those resources will continue to drain from the public system. And from a 2010 evidence synthesis of international wait time strategies, it found that private financing did not reduce public waiting times. And I think very simply, when we think about it, a privately financed system is only profitable if there are longer public waits. The private system demands long public waits. Otherwise, there is no business case for a private parallel system to be in operation. So just to pivot and spend a little bit of time about talking about what are the alternatives and what are actually the long-term solutions to reducing wait times for scheduled procedures and particularly surgeries. So what we know from the research literature and the experience, not only internationally, but from here in BC, and across the country, is that we need to focus on strengthening and transforming our public system. And much of this research comes out of a 2016 research paper that I co-authored with Marcy Cohen and Margaret McGregor, where we looked at the experience with public solutions here in BC, in some other provinces, including Saskatchewan, as well as Scotland, which has a similar organization to its publicly financed healthcare system like our own, where they have taken a tremendous amount of leadership in the public system to do what needs to be done to reduce wait times in the public system and sustain those over the long term. So I'm not going to spend a lot of time on all of these points, but I'll work through them as quickly as I can. So first is the focus needs to be on increasing and optimizing public sector acute care capacity over the long term, and avoiding what we often see in the Canadian context, which is short-term injections of funding to work down surgical backlogs. And we very much face this as we grapple with COVID and as we face the largest surgical backlog in Canadian history. So what we need to be doing, though, is not just increasing capacity in terms of new operating rooms or new acute care beds, but we first need to understand what is the capacity of the current organization of the system. Can capacity, based on the current way that services are organized, meet demand? If it cannot, can capacity be optimized based on redesigning how those services are structured? And we need to do it. And after we do that redesign work, if the capacity still can't meet the demand, we need to look at adding net new capacity. So that would probably mean bringing new ORs online, extending hours to perform surgeries into the evenings and weekends, and working ultimately to expand acute care capacity if that's required. I'm not going to spend a lot of time on it today, but I think one of the issues that does come up again and again, certainly in the Canadian context, is the attraction to outsource to for-profit clinics. But we know from the literature as well that this is not a long-term solution to these problems. And in fact, it raises many of the issues that we see and concerns we see with privately financed healthcare, albeit somewhat different. So again, it doesn't actually address many of the issues that I'm going to continue talking about. Secondly, we need to increase access to seniors' home and community care in Canada, across the country. One of the primary issues that we see in our hospitals is the issue of seniors who do not have community alternatives, whether that's long-term care, appropriate home support, or other supportive living arrangements. They may end up in hospital and are there until something appropriate comes up in the community, or families can patch together the appropriate supports, often by paying privately for seniors care, which, as we know, is not under the umbrella of Medicare in this country. So this remains a significant challenge, and it's been identified by medical associations and is one of the key strategies in terms of reducing wait times for everyone. Third, we need to see much better active waitlist management. This includes central intake, pooling referrals to see specialists and surgeons, and standardized team-based care pathways. And collectively, these are often referred to as single entry approaches or single entry models. And what it's intended to do is, rather than having your primary care provider refer you to an individual surgeon's wait list, where you may wait much longer for a consultation for a surgery you don't actually need, than had you been to refer to a central point of entry where there is a broader team. In the example of a possible knee replacement, you might first be assessed by a physiotherapist with the appropriate training, and then if you were seen to be a potential surgical candidate, you would then be referred on to a group of orthopedic surgeons who have who can see you quickly and based on a much more an amount of time that isn't highly variable, as might be the case with individual surgeons in the way that our system is currently structured now. So the point here is that these are ways to streamline and create efficiencies in how people are referred to provide much more rapid access to care, and much more coordination in how those services are delivered. The fourth point is to reduce clinically inappropriate diagnostic testing and surgeries. We know that around 30% of diagnostic testing, surgeries, pharmaceutical treatments, all healthcare services are potentially unnecessary. And in many cases, they may have no clinical benefit, and in other cases, they may actually cause harm. And so there's much work to do in Canada, as everywhere, to address these issues of clinically inappropriate or unnecessary care. And then ultimately, we need to think more upstream. We need to improve the health of our population and address the socioeconomic determinants of health, including income inequality and poverty, that actually make people sick in the first place. And so this is a much bigger endeavor, but I think we can't forget that testing and other surgeries, we see outcomes that are reflective of where people sit on the socioeconomic ladder. And so if we can't and we don't address that, we're not addressing some of the more systemic issues that we face. And then I just want to close with talking about some of the barriers. And I think in light of a Cambie decision, if depending on what that looks like, but regardless of what that looks like, we need to be proactive about addressing the barriers that we have faced in advancing these policy solutions. So that includes an honest assessment of capacity challenges for publicly funded and publicly nonprofit provided acute care and seniors care in this country. Both there is an issue of funding, whether it's keeping up, and certainly in the seniors care sector, I think we have much to do in that regard. But then also potentially a more challenging and more complex issue of service organization and integration. How does acute care and seniors care integrate, and how do we think of it as a system rather than these parts of our broadly conceived healthcare system that are not so much a system, but component parts, and thinking about how we do a much better job of organizing and integrating those services in order to ensure that people don't end up in hospital when they don't need to be, but also that we streamline and make much more efficient use of existing capacity. The second issue, and this is really one of the big points coming out of the 2016 paper that we did, was that in Canada, and particularly in BC, which is the main example, we see lots of very positive pockets of public innovation and improvement led by physicians and surgeons, other healthcare professionals, system administrators, but we have seen limited system level change. And so in many respects, we haven't changed the basic structure of how public healthcare is delivered in this country since Medicare was established. And so often these public system improvements fail to be scaled up and spread and made standard practice at a provincial level, and sometimes not even at a regional level. One of the key barriers we also see is fee-for-service compensation tends to perpetuate physician, clinical, and business autonomy. So predominantly, doctors and surgeons are paid per procedure they perform rather than a salaried or capitated payment approach. which would reduce the disincentives for physicians working with a broader team of healthcare providers. So this means that there are financial disincentives if work is to be done by other healthcare providers who are capable and have the appropriate clinical expertise to be doing that work. And then lastly, we've seen very promising work over the last 2 decades, but we do have more work to do improving data collection, public reporting, and accountability to drive system level change across the country and be much more coordinated as a national healthcare system rather than provincial and regional health systems that are often not necessarily linked up and driven by the timely data that would help them to improve and would equip frontline healthcare providers and system administrators and health authorities with the data to be able to identify where the issues are and how to improve them. So I will stop there.